Hello and welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor of JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
And of course, if you're following along live, send us your questions or comments on Twitter at JAMA Network Open or in the comment box under the video on YouTube or Facebook. Unfortunately, the very sad news we have today is that today is Angel Desai's last day as Fishbein Fellow at JAMA. So this is going to be her last episode of JNO Live with us. So Angel, we really appreciate all the wonderful work and incisive analysis you've done with us. It's just been really fantastic working with you and having you on the show. And so Emily put together a little video montage that we're going to show in your thanks.
Yeah.
Hi, I'm Dr. Angel Desai. I am a infectious disease specialist, but right now I'm doing a one-year Fishbein editorial fellowship. Thanks for having me. But I was wondering if you could just kind of go into that that thought process a little bit. And this is in your wheelhouse too, right?
Yeah. So we're trying to do what we can here.
Yeah. We're so excited about it.
Yeah.
I don't know why.
Which is,
I guess both, yeah. Optimism.
Right.
It's for a greater purpose.
Yeah.
So.
I mean, I do what I can.
I know.
Right. Yeah.
Again, I thought this was a really, really interesting topic, and really important. Did you have anything else that you wanted to mention about the study before we end today?
Oh, well, again, thank you for your hard work, Angel. I really appreciate it. And now moving back to the work. Our first paper today is a simulation of pool testing to identify patients with COVID-19 under conditions of limited test availability by Dr. Alhaji Sharif and colleagues. And we have first author, Dr. Alhaji Sharif, and senior author, Dr. Peter Katanko with us. Welcome.
Hello, good afternoon.
Thanks for having us.
Yeah, really glad you could join us. Thank you so much. This is a really interesting paper. So at first, you could just introduce yourselves, tell us a bit about why you did the study, and also explain exactly what is pool testing.
My name is Alhaji Sharif. I'm the senior research mathematician at the RI Institute. Peter?
Hi, yeah, and my name is Peter Kotenko. I'm a physician by training, an internist and a nephrologist, and I'm a research director at the Renal Research Institute in New York.
Great. So tell us, what is pool testing? I know a little bit about it, but I think it'd be good to hear it from the ground up.
Yeah, okay. Actually, pool testing is something that has been around for quite a while. I think at least the 1990s. And conceptually, pool testing is something really simple. Let me give you an example. Say you want to understand if a group of, say, 20 people are positive with a certain disease, in our case, COVID-19. Then you sample from each of those 20 subjects a swab, but take parts of this sample swab into one batch, or pool as it's called. And then you test this batch for the presence or absence of SARS-CoV-2. If it turns out that this batch is positive, then you are certain within the limits of the test that at least one member who contributed a sample to that pool has SARS-CoV-2 positivity. And then you go back to the other tests that you have collected, the quote-unquote the leftover test sample, the remainders, and test them individually. Now, if you test, on the other hand, the pool negative, then you can be certain, again, within the limits of the test's sensitivity, that all these 20 subjects are negative. So this is, I think, the sort of a broad concept. But what Alhaji worked on specifically is to dig a little bit deeper, because as you can imagine, there are a lot of factors that impact this. For example, the test sensitivity. For example, the test the prevalence of the disease in the population of interest, or also questions such how large the pool size should be. And this is actually where Alhaji conducted all his research into.
Yeah. So Peter, just summarizes the notion of pool-testing. So if you put this into a mathematical framework, so we're taking those characteristics, we try to look at how effective is pool-testing relative to a single individual testing, and then so putting those characteristics together, we look at relative cost, efficiency of the test, and also the most importantly, whether or not if you place patient in a pool, do you increase the probability of false negative, or do you reduce it? So that's what the impetus of the paper is.
All right. And I guess I guess pragmatic reason for it, or a practical reason would be that especially as we're seeing the numbers swell across the country now, we might be low on testing supplies, so we may not need limited supplies like reagents or something like that. We use once in a pool of say a dozen people. If they're all negative, it's not needed for each individual swab. Is that right?
Yes.
Okay, great. So tell us what you did in the study here.
So what we did, we basically wrote a set of mathematical equations that basically describe the expected number of tests that you need, and then also putting into consideration imperfect test characteristics like sensitivity and specificity. And the only thing we did not include in the paper is the dilution effect, which should be considered. But we look at what is the actual optimal size that you need in order to, one, have a cost efficiency, and also to reduce the number of false negative. So that's what the paper we did, and then we look at these different characteristics along. We assume also 100% test specificity, and then we look at different sensitivity from 60 to 100.
So I guess.
No, go ahead.
Yeah, so I guess really, as I said earlier, pool testing is around for quite a while, but these were all very special cases, like with hepatitis, like with HIV, and what we attempted here, what Al-Haji did, was actually to formalize a framework that can be applied on a more general level. So I think this is really what sets this work apart from other research in the field.
Yeah. The one question I had about this was that this type of model assumes that each individual has the same probability of being positive, correct?
Yes.
Yes. And when you think about different, I love the idea that this is a framework that you can apply for other infectious diseases. But I just kind of wondered about that a little bit, if you could speak to that.
So what we did in the model, so you assume it says population level, or maybe like a group prevalence. So that can then actually, it doesn't necessarily have to be the population level, but if let's say in a region, the prevalence is, let's say 1% or 2%, you can actually use that to characterize how to subdivide that group. So you don't actually have to look at the uniformity of the prevalence along population. You can actually look at the prevalence of each group. So we have that into the model. And then in some of the table in the paper, you saw different prevalence level that we incorporated. And then we tell you, okay, if you have, assuming that you have a total population of 94, and then what is the background prevalence, I can tell you basically what are the optimal subgrouping that you need to actually maintain some of the costs associated with them. So it doesn't necessarily have to be uniform.
That makes sense.
I'm going to welcome John Humphreys and Bernadette Keefe, who's joined us. We're talking about pool testing, or simulation of pool testing for COVID. And one of my first things that I thought about was, one of the strange things we're dealing with is that the tests still aren't very sensitive. They're probably in the range of 70 to 80% sensitive. So I was concerned about false negatives. But looking at the figure, what's interesting to me is how the rates of false negatives seems totally flat across the pool size. So that, I guess, would be figure the bottom left corner C. Can you talk about that at all?
So let's see. So if you look at, depending on the prevalence, so the false negative actually depend on the number of group size, the prevalence, and also the sensitivity. Right, so because we assume that the sensitivity is independent of the pool size, that's why actually it's flat there. But if you incorporate that correction, it may not be flat. Yeah.
It also seems interesting to me, just trying to make sense of these graphs, because this math is, a little more complicated than me. It looks like the K zeros or K naughts in figure A are the optimal pool size, and that as the prevalence goes up, the pool size goes down, or the optimal pool size goes down. And I guess my way of wrapping my head around that is that as you expect more people to be positive, you just know the pool size is going to be positive. The pool is going to be positive. There's not much gained.
Yeah, exactly. Yeah.
But at the same time, the cost savings, basically, every case seems to have cost savings at every number, essentially, right?
Excuse me?
It looks to me, if I'm reading this correctly, that basically every level of prevalence and every pool size does seem to have cost savings. Is that right?
Yes, all of them have cost saving up to 30%. Right, when the prevalence at 30, so that's when you drop from something like in some figure you go from 40 to like 4% cost saving. There's small cost saving, but the consequence of that, you actually introduce more. If you go beyond the 30%, you introduce more false negative. So to maintain that, you actually have to be below the 30% prevalence level in order to have some cost saving. But there are always cost saving, except when the prevalence is also high, then you might as well test every single one. Yeah.
Do you know, has anybody been implementing this? I saw something in a news article last week.
Yeah, actually, it's kind of interesting. So there is reports out of China that pool testing was applied in Wuhan, where they tested reportedly millions of people within just a week or something like that. Pool testing is applied in Israel in certain groups, and there is an ongoing discussion in Germany if pool testing should be used in, say, schools, for example, or other more congregated populations. So there is a discussion around that. And I think there exists also, from at least what we understand in China, positive experience with it.
Great. This is really fascinating. I think this is, the kind of thing that's unfortunately still relevant, and as our prevalence goes up across the country in a bunch of different areas, is unfortunately becoming more and more prevalent. So I really appreciate it. This is really important work. And as you said, this model, isn't specific to COVID and can be extended to pretty much anything in the future. So really fantastic work. Thanks for doing the work, and thanks for joining us.
Thank you for having us.
Thank you. Thank you for having us.
Great. Take care. All right. Angel, what do we have next?
All right. So this is another COVID-19 paper. This is the assessment of coronavirus disease 2019, community containment strategies in Shenzhen, China. Apologies if I mispronounced that. This is by Zhang and colleagues. And this was a study, a case series that was trying to describe measures that were enacted in a particular community in this region that were implemented to prevent the spread of COVID-19 and then evaluate that subsequent transmission that occurred following implementation of those measures. So they collected data from January to April of this year, looking at different sort of strategies that involved general practitioner and a community manager and public safety officials. And their main outcome was looking at the number of locally acquired cases that had indirect links to confirmed COVID-19 cases. So there are a little over 34,000 individuals that live in this community. 7 individuals with COVID that was acquired outside of the community were moved from quarantine to hospital in this study. 20 people were asymptomatic and who had contact with these and who had contact with those individuals with confirmed disease were observed at a hotel, and 800 individuals that were thought to just be at higher risk were moved from quarantine to home isolation for 14 days. And there were no locally acquired cases with indirect links in this community over the study period. And so this really suggests that these types of cooperative interventions, and I would say intensive interventions, may limit community transmission, which I think is a pretty important point as we continue to, or I shouldn't say we, but communities and public health officials continue to look at different strategies for containment.
Yeah, it's really interesting. Welcoming Kendrick Hicks has just joined us. We're looking at containment for COVID in Shenzhen. This is fascinating. I feel like, to be a little skeptical, it's hard. This is still relatively early. They went through, I think, April 10th. And then there's, I think lots of people have raised questions about numbers from Chinese officials, which, I think we all have some general skepticism everywhere. Even our numbers are suspect in a lot of different ways. And I looked quickly to see some of the reported numbers, and the whole province to date only has, I think, 1,600 cases and 8 deaths.
Yeah.
Impressive. And I think if nothing else shows that, good public health work can keep things under control if there is a level of control and level of effort. And unfortunately, it seems we've squandered a number of months, but hopefully we'll get better at it.
Yeah, agreed. I guess, yeah, you're right. I mean, this is really looking at containment, which is not necessarily the situation, right now elsewhere, but still sort of an interesting, I think, thing to think about.
Yeah, it's
important
interesting.
Thing.
And important, especially, hopefully, like in places like Chicago and Boston, where, we seem to have gone over a hump and things have slowed down a bit, we might be in the kind of situation where containment might be feasible at this point.
Yeah.
So on that positive note, I'm going to welcome Diva Gotor, who's joined us. Welcome. We're moving on to our next paper. This is we're done with COVID for the day. So this one is Socioeconomic and Demographic Characteristics of U.S. Adults Who Purchase Prescription Drugs from Other Countries by Hong and colleagues. This is an interesting and important topic. There's out-of-pocket costs for medicine in general are pretty expensive and substantial for a lot of people in the U.S. One strategy that some people use and that some policymakers have pushed is buying cheaper drugs from overseas or from other countries like Canada and Mexico, where the prices are lower for both health system reasons and potential quality reasons. And what they did in this study was look at, basically who is getting or who is reporting that they're getting drugs or medications from other countries currently. So they used the NHIS National Health Interview Survey from 2015-2017, asked a range of questions of their sample was, I think it was 61,000 U.S. adults who use prescription drugs. So it was a cohort of people who actually are prescribed medications. Some interesting things. First of all, one of the stats in here was, I think it was like 37% of Americans are on 5 or more drugs. Which is fascinating and sad in a number of ways, but it's certainly a relevant topic, and the out-of-pocket costs are huge for a lot of people. Only 1.5% of people of these people who are prescribed medications report purchasing out of the country, and then there's a number of associations they found. So the things that increase the chance of buying things out of the country are people who are older, people who are Hispanic, immigrants to the U.S., people with higher education, people with lower income. Not surprisingly, there were also a lot of things that kind of seem to coincide with higher need for lower costs, things like lack of insurance, poor health status, people who seek online health information, people who use online pharmacies, and people who skip or delay medication refills. Interestingly, poor health status shook out, but there wasn't a dose response to increase in comorbidities, which I don't know what to make of that at all, if anything. And some of it's only 1.5%, so it's the people who probably need it the most. Some of these seems like, like online health info seeking, seems like people who are savvier, but it also seems like, some people who, it's, I guess, in an observational survey like this, hard to tease out chickens versus eggs, and are people using online pharmacies or seeking health info because they have a higher need to keep their out-of-pocket costs low?
Right. It's interesting because when I read this initially, I didn't understand, it didn't make sense to me. Oh, if you have higher educational attainment, why would you be more likely to seek prescriptions outside of the country? But actually that kind of makes, I think the argument is that, potentially those individuals are have some different sort of health-seeking behaviors, potentially. So yeah, I thought it was really interesting. I couldn't believe how low it was, actually. I thought that it would have been higher just given the way how expensive prescription drugs can be in the U.S. So yeah, I was surprised.
Right. Yeah, and I'm curious if one of the confounders on that is that these are people who are already prescribed medications, so it's people who have some level of resource and need to get healthcare in the first place. Yeah. I think also one thing that I think limits the external validity or the applicability if we start doing policy interventions to allow this more is that these are people who are doing it in the current circumstance where it's not really it's mostly in a gray area. So I think if it's the kind of thing where, a third of people from Medicare are getting their drugs under some sort of drug importation program, then it would be very different. There's also, we've got a figure B, which we can show that payer status also varies. It varies a lot among payer status, not surprisingly. And people who are uninsured, or I guess probably fall into the uninsured camp, like people on the Obamacare marketplaces, are more likely to get medications from other countries. Also, people who have Medicare without either Medicaid, Medicare Part D, or private Medicare, Medicare Advantage, which those are all the basically add-ons to Medicare that allow you to have some more prescription drug coverage than basic Medicare, which all makes a lot of sense to me.
Yeah, I think that makes sense. I can't recall, there wasn't a table in there that broke down the type of prescription drugs, right? Is that something that was sort of, I was thinking about? I would just be curious to see, if it ended up falling along sort of the type of drug.
Yeah, there were, they reported some of the selected chronic conditions, and there were differences that were basically minuscule between things like COPD and diabetes and hypertension and cancer. There weren't differences that were dramatic and worth showing, basically.
Yeah, okay.
And also, again, I'm figuring out how to make sense of results, so I might be completely wrong. But it also makes sense that people who are immigrants or Hispanic might have more ties to, say, communities where they can, have ease of getting drugs. Like I vacation to Mexico, and there's pharmacies where it's a lot easier to get kind of drugs that are only available prescription in the U.S. I remember the first time I went to Mexico into a pharmacy, I was like, I can buy Levaquin and gabapentin. Why do I want to buy that myself?
Yes.
Yeah. And then the authors talk about some of the important things like potential fraudulent or quality issues in getting drugs overseas. And not all, but a small part of the reason why drugs are more expensive in the U.S. is because of quality assurance here. Yeah. There's tighter regulations, and you're more likely for the drug that you're buying to actually contain what it's supposed to contain and only what it's supposed to contain. Unlike our vitamin supplements, which we've talked about. Whole other topic. More paper for us.
Yes, so this is association of household exposure to primary Clostridioides difficile infection with secondary infection in family members. So you know me, I always love a good C-diff paper. And this was actually looking at the incidence of family transmission of C-diff infection. So it was a case control study that looked at the incidence of CDI among individuals with a prior exposure to a family member that had been diagnosed with the CDI to those without. They used market scan data, and their primary outcome was the incidence of CDI in a given monthly enrollment stratum. I thought this was super, super interesting for a few different reasons, but in any case, they found over 200,000 cases of CDI in families with at least 2 enrollees. And of these, almost 5% occurred following diagnosis in a separate family member. And this was found to be significant, statistically significant association. And it was also found to be having a familial member that was diagnosed, or having an exposure to a familial member that was diagnosed, was the second highest risk factor for developing a C. diff infection after a hospital exposure. So really interesting. I mean, certainly there's a fair amount of C. diff that is treated, or the treatment is started in the hospital, but we also have a lot of patients that are on antibiotics as outpatients that develop C. diff infection. They are started on the appropriate therapy once that is diagnosed, but I hadn't thought about, or I don't know if we think enough about family members that are in the area, and transmission, and from that fomite transmission, I guess I should say, from that perspective.
Yeah, it's fascinating. Kaylee Hampett, welcome. We're talking about C. diff infections from family members. This is a really fascinating study, and the magnitude of the association they found is just stunning. It's like 12 to 21% more likely to get C. diff if you have a family member who does. Obviously, there's limitations. This is from administrative billing data from an insurance claims, which makes it hard to draw big conclusions from. And they couldn't correct for things like common risk factors like IBD, which is familial, will have a common exposure.
Right.
But again, just the fact that most people are getting them in a hospital, and then I don't know, is a family member visiting them? Is it being around the family member when they come home? I'm just fascinating. It's also been fascinating just over the arc of my what I still consider a relatively short career, C. diff has gone from something that only people with risk factors like hospitalization or antibiotics have to something where really anybody can have at any time. And we changed the name too, although we kept the abbreviations the same, so that's good.
We did, yeah. You know, I had looked up the whole reasoning behind that at one point, and I wish I had brought it here. But it is taxonomy is very interesting, or taxonomy, I guess.
Absolutely, yeah. So really fascinating stuff. Learning more about C. diff, and also, you know, I think there's unfortunately some parallels here to what we're learning about things like COVID, healthcare workers, health workers, exposure to family members. You know, a lot of the data we're seeing now, it seems once we've identified COVID in a place or that place got savvy, that the healthcare workers are getting most of their exposures from their home or the community and not necessarily at work. So it just strikes me as some interesting parallels here. So to bring everything back.
Yes. Exactly.
Yeah.
Full circle.
Yep. So that's all we got for today. Of course, you can get these papers and more at jamanetworkopen.com. Everything's free and open access. Get new papers every day, every weekday at 10 a.m. Central Time. We are going to take next week off for the holiday, for Independence Day. So join me again back on July 14th, but unfortunately not Angel because she's leaving us and going to California. Angel, again, can't express how great it's been working with you. You've just been a fantastic member of the team here. Couldn't have really done it without you. And I really wish you all the best going forward.
Thank you so much. And I want to thank you and everybody behind the scenes that has been so helpful and welcoming. And I'll miss you guys, but I'll be watching in a non-creepy way.
All right. Well, great. Well, everybody stay safe and take care.